We've all been told to go minimally invasive. Tiny flaps, keyhole access, drilling. It sounds modern and gentle, but here's the biological problem. Minimally invasive often means biologically aggressive. When you cut less, you see less. When you see less, you control less. And when blood supply and tension control are compromised, biology pays the price. Today, we'll break down why less cutting isn't always less trauma and how optimally invasive surgery protects the tissue, perfusion, and final result. After 30 years in surgery, I've learned that biology drives success. This channel explores implant and oral surgery, how the body responds, how we can improve healing, and what the science shows and how disciplined surgical execution turns evidence into results. Welcome back. Today, we're covering why gentle surgery can become biologically aggressive and what optimally invasive really means. Minimally invasive isn't a surgical principle, it's a marketing term. True surgical refinement balances three biological imperatives: perfusion, because tissue must stay alive; access, because visibility and control must be complete; and passivity, closure must be tension-free. Flapless or microflap surgery often compromises one or more. If you can't fully release the periosteum, tension increases. If you can't see bone morphology, graft adaptation, membrane positioning, or implant placement suffer. If you don't elevate enough to preserve or reanastomose blood vessels, ischemia follows. Less trauma means less biologic trauma, not less incision length. Histologic and microangiographic studies show that flap elevation, when done properly, causes transient perfusion loss that recovers within days. But flap tension and incomplete release delay revascularization and fibroblast migration. Preserves in 2004 demonstrated increased crestal bone loss in flapless implant placements due to poor visibility and over-preparation. Stacchi in 2013 showed controlled full-thickness flaps with tension release actually improve healing outcomes compared to limited flaps that leave residual tension. Perfusion is geometry dependent. Blood flow in a minimal flap under stress is lower than a wide, relaxed flap with full perfusion. Optimally invasive surgery means access what you need, no more, no less. Protect perfusion, sharp dissection, clean planes, minimal crush injury. Release precisely, achieve tension-free closure without strangling tissue. Respect soft tissue biology. The goal is oxygen delivery and cell migration, not simply a small scar. In practical terms, small incisions for diagnostic exposure only, full access when grafting or augmenting or placing difficult implants. Always think, can I see the problem, solve it cleanly, and close tension-free? Minimally invasive often limits control and visibility. Optimal invasiveness restores control, preserves blood flow, and ensures closure that heals by primary intention. Next time you plan a flapless or micro-access, ask three questions. Can I visualize the critical anatomy? Can I adapt my implant placement, the graft, and membrane without guesswork? Can I close passively without strangling perfusion? If any answer is no, go bigger. The incision doesn't define trauma, technique does. Gentle hands and clear vision create predictable healing. Optimally invasive surgery respects biology, not trends. If you found this useful, please like and subscribe to see the videos that we upload every week. And comment below, please, when do you still go flapless and why? Thank you.